no two doctors document the same way. If it says family history of cancer, it doesn't mean I have leukemia.
What is the biggest challenge in data normalization today? Like, because sounds like it should be a fairly, I want to say straightforward thing, but I don't think people appreciate how difficult normalization really is.
Absolutely. I think it's an incredibly complex task. And, I said I wrote the business case for it, but when I wrote the business case for it, I had underestimated the complexity of what I was embarking on. And I think, over a period of where I've seen so many use cases, so many ways of documenting things. So for example, a simple thing, I gave you the COVID-19 example that one of my mentors and colleagues, I got that from him. Simple thing. We go to the doctor every year and get a physical, and the doctor invariably checks our hemoglobin A1C. A simple test like a hemoglobin A1C, right? I have seen so many different, glycosylated hemoglobin. It can be called HGB, HGBS A1C, HGB A1C. Now the question, that's a fundamental challenge that I alluded to before, is the variability of it, right? And it's shocking how non-standardized it is. And it has real life impacts downstream, right? Now, if you're trying to control a pandemic and you're trying to figure out how many people are negative and positive, and you can't even define a negative and a positive in a standardized way, just imagine how hard it is for public health experts to be able to glean that information from data. If there's data coming about a patient from outside health systems, suppose I moved from Delaware to Illinois, and my data is coming in from the outside into a hospital that I'm going to in Illinois. Just imagine if they cannot track a trend in my hemoglobin A1Cs over a period of time. Does that have an impact on how I'm treated? Maybe. It's possible, right? I'm using an overly simplified example. It's possible. And as it gets more complex, this information loss that happens because of this non-standardized way of documenting things, it has real world impacts on researchers, on public health experts, on clinicians who are trying to take care of people in the end, right? So, but then there is also, that's only like getting structured data like a lab test, right? I just talked about that. What about normalization? It's not limited to that, right? As we know, we go to a doctor's office and the doctor is furiously typing on the keyboard. We all have had that experience post-EHR world. What are they typing into? They're typing into a narrative about you, about a history and physical, or a progress note, whatever it is. And all that interesting stuff about me as an individual, or me as or others as patients, is going into that narrative, and each documentation style is different. And no two doctors document the same way. And then you have to understand the context in which the medical concept is written. So, for example, if you don't understand assertion, probably if it says family history of cancer or family history of leukemia, it doesn't mean I have leukemia. It means I have family history of leukemia. So the assertion status becomes important. It says no patient reports no nausea. That means I don't have nausea, because even though nausea is reported in the document. So the negation becomes important. So these are simpler examples. But then if I say a patient has diabetes with stage 3 kidney disease, but diabetes is in paragraph 1 and stage 3 kidney disease is in paragraph 3, or maybe retinopathy is in paragraph 4. Now, you need to have a document level understanding to be able to say that, oh, this person has diabetes. Because of that, they have stage 3 kidney disease. And because of that, they have retinopathy, maybe, right? So to be able to have document level understanding is also a big challenge. So these are some of the complex challenges to clinical data, especially when you're trying to deploy it for secondary uses downstream. For primary uses, it's a problem in itself because of treatment and things like that. For secondary uses where you don't have access to the person who actually documented it, that becomes even more problematic.
It was an interesting concept I was discussing with someone just actually yesterday. What about the concept of, I would call it, they were talking about data decay, but I think about a definition decay. And let me explain what I'm thinking about there. The way that we define something, and I think you were talking about this when you're talking about your sets, right, changes over time. And actually, just like language changes over time, there's a vernacular essentially to human speech that, we have every year new words that are added to the dictionary, and, we don't throw out the old words, but we stop using them, or the meanings of things change over time. And so how do you think about and adapt to this kind of, world in flux over time?
Right. So at IMO Health, I think it's constant surveillance in the sense that at IMO Health, a large part of our staff, we are a 300-person company. A large part of our staff are, clinical terminologists. That means they have clinical backgrounds and they are also experts in healthcare terminology. So they have this dual expertise, and we are always, we release we call them domains, and I don't want to assume that everybody knows what that means. For us, a problem and diagnosis is a domain, and procedures are a domain, a lab is a domain, and so on, and so immunizations is a domain, and so on and so forth. For various ones of these domains, there are multiple releases of content. And what does content mean? It means definitions of what a medical concept means. So if you think about how IMO Health came about, it's about understanding that people document things in the language, in the clinically friendly language. That means in a language that they're comfortable with, but they also know that there's semantic equivalence even though they use different terms. Over 30 years, we've created an editorial policy around how do you curate these terms, because we hear from our customers the different ways of defining things and what they mean, more importantly. And then how do you completely and accurately code that using coding systems that are available, like ICD-10. So a lot of the time, there's a medical concept, there's a meaning of that medical concept, and it's not just one ICD term that would define it or one SNOMED term that defines it. It will be multiple things to understand, like, malignant neoplasm of the breast, metastasized to pelvis is a very common example we use within, but it's a compound sort of diagnosis. It's not just one ICD. There's no one ICD code. There's no just one SNOMED code for a compound diagnosis like that. It's multiple things. Way we deal with definitional decay or information decay that like you said, was to constantly, have this surveillance mechanism through tools that we have internally, but more importantly, the people who are trained to understand this, the changing nature of these definitions, and have multiple releases of this content so that others who can benefit from that, our customers can actually benefit from that.